Hello everyone, I'm Mr. Randhir Chavan, medical retina consultant at Birmingham Midlands Eye Center, United Kingdom, and I'm going to talk about subthreshold micropulse navigated retinal laser, especially for the use of in CSR. And I'm going to talk more about the Navilas laser systems for the use of this micropulse laser. So I had presented this talk in our MRUS meet locally, that is Midlands and Retina Uveitis Society meet in December 21, and I would like to share that presentation as well. So a bit of background about why I got interested in micropulse laser. So we've been using photodynamic therapy PDT for all our CSR patients without any problems till 2019. In fact, we had an audit with brilliant results of the CSR patients, but in 2019 the ownership of verteporfin changed, and since then we have been having difficulty getting hold of verteporfin. It is still available with some difficulty in patients with wet AMD and IPCV, but as there is no nice guidelines for use in CSR, and there is no CCG level agreement for to be used in CSR, it is very difficult for us to get hold of Visudine for PDT in CSR patients. You could do individual funding requests, which can take a lot of time, and often it is not approved as it is not considered as an exceptional case. So we were having great difficulty in 2020, and I was just trying to think about, in fact, I had sent a letter also to all the regional units saying that like roughly we annually accepted about 25 to 30 patients of CSR to be considered for PDT, but we were no longer accepting these patients. So I was thinking, are there any alternatives? And I was trying to look into literature about, other treatment modalities. So if you look in literature, there are these retrospective papers that are there which compare a micropulse laser with a PDT laser, and many of them initially showed that in fact micropulse laser was slightly superior to PDT laser. So this one published in Eye in 2016, this one from 2018 again showing that it is probably superior, so micropulse laser being a bit superior over PDT. These are retrospective studies, and this paper was published by the lead author is Mr. Chablani, who is immensely experienced in using micropulse laser, and I have attended some workshops as well. Again, this is something that I came across attending some workshops. This was a talk given by Dr. Francesca from France, and she outlined that most of the results, if you look into literature, micropulse laser was at least comparable with PDT, but in PLACE trial, that's the only randomized control trial, we all know that micropulse laser was found to be inferior to PDT, and that is where we've all been using PDT. So a bit about micropulse laser. So if you think about a continuous wave laser, that is our normal laser, so you get a continuous wave laser that causes tissue coagulation. That is because you get a rise in the tissue temperature, and that is how coagulation comes up. So, but in micropulse laser, rather than it being a continuous pulse, the energy is delivered in repetitive short pulses. And this repetitive short pulses, actually the tissue temperature does not go up, and that is how basically a micropulse laser has an advantage of not increasing the tissue temperature. So the laser energy is delivered in short pulses, and in between time allows for the heat dissipation, and this prevents any thermal structural tissue damage. So coming to Navilas laser, I got more interested in Navilas because it has some advantages over other lasers. That is, you can plan the whole of the treatment. So on Navilas, you can get these two screens. You take a picture, and then once your picture is there, you can plan the whole treatment. You can put your caution zones around the disc and the fovea so that so that your laser is not so that it's much safer. Again, advantage is that you can overlay your FFA and OCT images and plan exactly. So there is more precision in what you are doing, and you can directly visualize everything that you have planned, and at the end you get a report as well, which will tell us exactly what treatment has been done. So these are the advantages of Navilas laser over other lasers. I will come to other advantages as well. So Navilas have organized some workshops and I've been attending them, and I was more interested in looking at the parameters that were used for CSR patients. So the most important thing that I learned was that it's very important to have confluent laser burns, and you can even give it in the subfoveal areas as well, and the spot size being 100 microns, and the pulse duration being 100 milliseconds, and the duty cycle after you have titrated should be 5% duty cycle of the barely visible burn, and once you get the visible burn, you reduced the energy by about 30%. So I will come exactly to that. So these are the parameters, sorry, these are the laser settings that have been recommended by Dr. Chablani, and I have been using these. So this is what I generally plan. So I put on the caution zones onto the disc and the fovea, and then I plan out all the area where I have to do the laser, and your spot size, as I said, is 100 microns. So the most important thing I think is the spacing between that should be completely zero. So you give absolute confluent burns. I think that is the key for micropulse to work. And other settings are you get infrared, so that's not a visible light, and 5% of the duty cycle. Now we'll come to the titration bit because that's an important part where it is recommended that you get a barely visible burn and then you drop down your energy to 30%. In my experience, trying to find this barely visible burn can be a bit of an hit and miss. So sometimes when I think that there is a barely visible burn and I still slightly increase the power, there is a significant amount of visible burn that I see. So I've not been very happy trying to titrate based on that, but I've looked at what they generally use, what millivolts are generally used. So they would start with about 240 and it would go to about 330, 360. So when you are near to the fovea, you can start using about 240, 200 to 240 millivolts, and as you are going well away from the fovea, you can increase the power. If there is more pigmented eyes, you can reduce the power. So rather than absolutely going by titration, I'm going by general parameters that are there of what millivolts to be used. So several advantages of Navilas laser over conventional lasers. As I mentioned, it is much more comfortable because it's infrared light, and it's safer for the patients because you have completely pre-planned the treatment and you have put your optic disc and fovea caution zones. And most important, again, accurate spots are delivered. Each laser burn counts. And as I said, you can overlay FFA and OCTs for better treatment planning. Again, it's a non-contact way of delivering focal laser, so it's much more comfortable. And from my point of view, the most important advantage is the true confluent nature of the burns. So how does it work? So the proposed mechanism is that this laser impulses, they are absorbed by the chromophores in the retinal pigment epithelium, and they are dissipated in the form of heat. And once this heat is dissipated, it causes an increased expression of heat shock proteins, and these heat shock proteins are supposed to improve the pumping efficiency of the RP. And through these workshops, I've also understood that if you are you don't just treat the leaking spots, but you can, if there's a large amount of subretinal fluid as well, you can treat in that area because it is micropulse subthreshold, which is much more safer, and all you are doing is trying and stimulating the RP so that it works better. So just coming to the PLACE trial. So we all know that PLACE trial showed that PDT is superior to micropulse laser. So consultants and doctors who have been using micropulse laser for a long time, their argument about against the drawbacks of this paper is that they agree that PDT in this has shown that it is superior, but the laser that was used is 810 nanometers laser wavelength, whereas Navilas we know is 577. So it's a completely different wavelength that was used. And if you look at how those micropulse spots were delivered, so they concentrated only on the areas where there was a choroidal leak based on the ICG and not on OCT. And whereas it is now recommended that you not only treat the hot spots and the leaking areas on ICG, but you also should treat all the area where there is subretinal fluid present as well, so that you are stimulating the RP. So slightly different way of how you are delivering the laser, rather than just going by doing laser onto the hot spots or to the leaking areas. So doing lasers in areas where there is subretinal fluid as well. So based on this, my experience so far is in BMEC, I have done about 18 patients till December 21. Out of that, 12 were CSR patients, 3 DMO patients who were not keen for injections. I've done some vein occlusions as well to try and reduce the amount of anti-VEGF and Osidex. And in one course patient who had very poor response to previous Osidex and laser, I've done micropulse as well, but I don't have the results of that yet of this court patient. So this was my first patient. So first I did on a DMO patient whose vision was 612, 618, and he had this subretinal fluid present. He was absolutely not keen for any anti-VEGF injections. And this is after the micropulse laser. So you can see the subretinal fluid has reduced. And I'll just come to the settings that were used. So all this area where there is leaking areas. So see, even in this area, the number of spots delivered is about 461. So you can see true confluent burns, you can deliver a lot of spots, and that is probably the key to micropulse, delivering a lot of spots in a confluent manner. And so that was the first patient. So I started off with the DMO patient, and this is the CSR patient. So this is a 30-year-old football player. He was very anxious, very symptomatic with his CSR, and for about 6 months or so. And interestingly, on FA and ICG, his hot spots, all his leaking was not around the foveal area, but was in the papillomacular bundle just next to the optic disc. So I'm not sure how good it would have been to do PDT on this patient anyway, but that was the area. I've discussed everything with him and we went ahead and did. So this is his OCT. So fovea was not involved, but he had subretinal fluid in that area where the hot spots were. So you can see this is my first case where the caution zone in the fovea is much bigger than the optic disc. And but anyway, so I've done confluent burns in the area where it was leaking from. I did some in the subretinal fluid area as well. And this is him 6 months after the laser treatment. 6/6 vision, he's asymptomatic, got a very tiny amount of subretinal fluid there, but more or less it's gone. He's very happy with the result. My second patient was a 51-year-old Asian patient with poor vision in the left eye related to CSR, and he was now symptomatic with his right eye with 6/9 vision, and the FFA being hotspot very close to the fovea. So this is his subretinal fluid in his good eye, the right eye, just under the fovea, so very symptomatic with that. and you can see that his hotspot was around there, now very close to the fovea again. So I've done quite confluent burns. So even in that area, I've done about 187 spots delivered. And the importance is the confluent burn. So he's 6'4" in that eye. He's quite happy and asymptomatic at 6 months of follow-up. And we've got the next patient is a 59-year-old Asian male. Again, poor vision in the left eye because of CSR, and he is now symptomatic with his right eye having chronic CSR. So that's his right eye FFA. So you've got this hotspot and you got a classical smokestack kind of appearance there. So this was all laser that I've done. So even in that area, so I've also targeted the subretinal fluid area, and obviously where good confluent burns, where he had the high amount of leakage. So this is him before the laser treatment. So you can see the subretinal fluid there with small PEDs, and it's the same cut number 88. And if you look at his subretinal fluid compared to before the laser has definitely reduced. There is a slight increase in PED. Now this is again something that I have understood from the workshops. One or two people have mentioned that immediately after the laser, sometimes the PED can increase in its size. If you think about it, if the subretinal fluid is being pumped under the RP, you could have a small increase in pigment epithelial detachment. Anyway, that was him, a slightly inferior cut as well. Same area, scan cut is 122, and you can see all that subretinal fluid is gone. So that's the thickness map indicating the change. So again, he's 6'9", very happy. So the next case is a case which was referred from Dudley, and he had right CSR since 2016. In fact, he was seen in BMEC in February 2020 when he had focal laser to that hotspot, so that particular hotspot, and his subretinal fluid was slightly better, but there was recurrence of fluid in March 21. The vision had dropped to 624. Extremely thin outer nuclear layer. He was happy to proceed with micropulse, but had given him guarded prognosis. And that was, so again, even in that small area, you can see that 454 spots were delivered, and I've covered all that area. And this was him before the subretinal fluid that was present, and this is him 6-month follow-up, no subretinal fluid there. His vision is still 618, but he is slightly less symptomatic now. Case 5 is had persistent subretinal fluid for more than a year, a single hotspot, and next to the major blood vessel with 618 vision. So this is the only hotspot that was present. Interestingly, after the laser was done, so this is the top OCT is before the laser was done. So you can see the thickness map. The whole of the subretinal fluid is in that superior area, and this is him after. So he's still got a lot of subretinal fluid, but you can see that all the superior subretinal fluid is gone, and he's got this inferior. So the subretinal fluid has actually shifted. Probably that leaking spot has stopped, and it would be interesting to see him after a while, in about 3-4 months, to see whether he's doing better. So this is a patient who, again, very anxious patient. Is a 43-year-old accountant, and he had a lot of stressful medical conditions, in which he had a pontine cavernoma hemorrhage in December 2020, and since then developed CSR as well, which was there for 6 months. A very anxious patient with a lot of questions. So I found that somebody who's very anxious and needs to know a lot, it is very important to give them all the information. So I always tell them that the gold standard is PDT, and it is very difficult to get hold of PDT at the moment. I also inform them about PLACE trial, tell them about how that randomized control trial showed that it is PDT is superior to micropulse, and I offer them observation and also micropulse. So it's all about informing them. So this is where his hotspot was. This is all the leaking area there. So I've covered that entire area, and I've also done some in the subretinal fluid area. And this is him just 1 month after that. I don't have follow-up after that, and that's why I've just included this. So this is just 1 month after. There is definitely some reduction in the fluid, as you can see, but it would be interesting to see him after 3 to 4 months to see if it's resolved or if it is if there is still some persistent fluid. Now I will come to the ones that have responded poorly. So this one is a 49-year-old male who was referred from Worcester. This has been going on since 2018. He had recurrent CSR since 2016, and CSR in the left eye with vision of 618. PDT was done in 2019. And this was his FFA and ICG before the PDT. And so the important thing, so this was after the PDT where the subretinal fluid reduced, but he was still symptomatic. And when he came in September, he had this huge recurrence of subretinal fluid. But again, if we look at the FFA and ICG, there are not many hotspots or not many leaking areas around the foveal area. So there is just one hotspot on the top there, and that's about it. So again, he had a lot of questions. So I've explained in details that the main treatment would be PDT, but it is not currently available in NHS, or there can be a significant delay. And I will have to do an IFR, which is unlikely to be approved given his vision and not an exceptional case. And again, discussed about place trials. Private options were also discussed. In fact, he informed me that he is happy to go ahead with the micropulse as there are very little side effects, but he would also like to explore the private option. So I did his PDT. So see, in all that area, I've done about 813 spots delivered. So complete confluent burns. So he came back just 2 weeks after his laser because he thought that his symptoms are getting worse. In fact, 1 week after his PDT, he had been to see somebody privately in Moorfields as well, and he had all the investigations done, and he was told that Visudine was not available till at least January. So there is a shortage going on of Visudine, and very difficult to get hold of it. And another patient who had poor response is again chronic CSR for more than a year, and the left eye worse than the right eye. He was seen in Turkey in 2020, and since then he has been on Diamox. He was on Diamox, but the SRF hadn't changed. So that's his left eye, a lot of subretinal fluid in the subfoveal area. So if you look at, again, the interesting thing is if you look at the foveal area, there is no hotspots there, and there's an hotspot there and ICG leakage in this area. So these patients who have had poor response, I will come to them, but so I did a lot in the hotspot area wherever the subretinal fluid was, but he absolutely had no response at all, and he was not happy, and I gave him the private option again. He went and he managed to have PDT done, and he came back for a follow-up to me as well, and following the PDT, it's completely resolved. So probably the vein occlusion, micropulse doesn't work in every patient, and I think from what I've learned from these cases who have had poor response, if there is not much leakage on the FFA and ICG, so it could be more of a sick retinal pigment epithelium, and because of the sick retinal pigment epithelium, you are trying to stimulate that RP that is already sick, and it doesn't work, and probably PDT is a better option in if you can get hold of it, is probably a better option. Now This is a vein occlusion patient which was referred to me to try micropulse laser because he had had 13 Eylea injections, 3 Osodex, 4 times focal laser, but always had poor response. So that was him. And so first thing is I advised him to have another Osodex. So this is his OCT scan 1 month after his Osodex was done. Obviously brilliant response. And while the fluid was less with Osodex, I have decided to do some laser at that time, micropulse laser. So even in that area, I've done about 875 confluent laser burns. And this was him before the laser. And there has been slight reduction in the subretinal fluid and intraretinal fluid. And there has been not completely resolved, but there is some response that is there. At least hopefully long-term aim is that that will reduce the amount of anti-VEGF injections or Osodex injections that are required. And this is another patient who was referred to me with query codes. Again, he's had lots of anti-VEGFs and focal laser and Osodex. And that was all his telangiectatic areas that were leaking. And I have done subthreshold laser in that area. He's unfortunate. This is just I've not seen him since then. As I said, this was presented in December 21, and I had just 3 weeks of follow-up after that. So once I review him, I will update about him how he's got on. So just my initial experience. So I've done about 12 CSR patients now. 4 patients I've got less than 1 month of follow-up, so it's difficult to say whether it's worked or not in those patients. 2 patients I've just got 1 month follow-up. One of them have had some reduction in subretinal fluid. One has had a poor response. So the 6 patients out of the 12 in which I've had more than 6 months of follow-up, subretinal fluid has been absent in 4 of these patients. In one, the subretinal fluid is less but still present, and one patient has had a poor response and has had PDT since then, which was a good response. At least it resolved his subretinal fluid. So this is my initial experience with Navilas at the eye center. I would definitely say that as it is very difficult to get hold of Visudine and do PDT on a regular basis, this is certainly should be considered as an alternative for these CSR patients as PDT is not readily available. And what I've learned from these patients is if there is a complete absence of hotspots and but there is a lot of subretinal fluid present, then it's a slightly chronic CSR because of sick RP and significant retinal pigment epithelial changes. So the pump mechanism of the RP is not working very well and I think in these patients your micropulse laser is not going to work, and probably you have to if available you do PDT, and I've used it as an adjuvant in some other established treatment as well, basically to reduce the need for anti-VEGF or Osodex injections. So that's my experience of using micropulse laser at BMEC. Thank you for listening.